Hi everyone, it's Dr. Crad. In this video, I will be sharing some surgical pearls with the Clearview 3 lens implant. I'll show you how to ensure a safe delivery, safe rotation, how to center it, and even its explantation. If you are implanting or considering implanting the Clearview 3 lens for patients, this video is for you. The Clearview 3 lens has two optical segments, one for far, another for near, with a transition zone in between. It has a closed loop haptic design, and the haptic on the near vision side has a round hole. This hole is supposed to be on the leading right side during implantation. Make sure you are attentive to this during implantation to ensure the IOL is oriented properly. You can see the hole within the nozzle during implantation. Noting its relative position in the nozzle will indicate whether you need to rotate the nozzle clockwise or counterclockwise to deliver it in a planar fashion. Here's a case where during implantation, I noticed no visible hole in the leading haptic. My surgical tech accidentally loaded the lens backwards. You must stay attentive, and thankfully I catch this before delivering the lens in the eye. I will easily unload the lens and reload it properly. This leads me to my next pearl. Learn how to load the lens yourself. After reloading the lens, it delivers perfectly. The nozzle fits fully through a 2.75mm incision, and I would recommend starting with this incision size. However, the lens can also be inserted through a 2.4mm incision via wound assist. Use your second instrument to keep some counter traction via the paracentesis, and use the push plunger. There is also a rotating plunger available to insert the Clearview. Some surgeons have told me they struggle to rotate the lens into position after implantation. They say the lens feels snug in the bag and it's resistant to rotation. It shouldn't be that way. This usually occurs when trying to rotate the lens under viscoelastic. My advice is to remove the viscoelastic prior to rotating the lens. Viscoelastic is viscous. There's more resistance when you try to rotate the lens in a sludge-like gel. Removing the viscoelastic first allows the lens to freely swim in BSS. It will rotate without any resistance. See here how I rotate the lens? It moves very easily. You don't even need a hook. Just tap the periphery of the lens and nudge it either clockwise or counterclockwise. I keep irrigation on with my IA tip, and if I use a cannula, I'm irrigating during the maneuver. In regards to lens centration, I've been centering the visual axis paracentrally. I align the visual axis adjacent to the center of the lens. I bias the centration slightly towards the far distance optic. I want my patients to have great far vision. Reading vision is important too, of course, but I don't want to give the patient good reading vision and mess up their far vision. Good far vision is my default. The reading segment is a bonus. I use a Zyscope, and there are 3 lights, and one of the lights you can turn on and off, and that can allow the patient to fixate on that light. You can essentially make it a fixation light to ensure you are aligning the lens on the patient's visual axis. So here we have a patient trying to look at all the lights, and they're moving so much. And so we simply tell them, stay on the strip of light, the small one. Don't move away from it. All right? That's perfect. Stay right there, okay? And just like that, the patient knows precisely where to look. Because this light is distinct from the others, I can be confident knowing that the patient is looking where I am asking them to. Make sure preoperatively that your patient doesn't have tiny pupils. You need light to pass through both segments of the lens implant. And with small pupils, the iris is going to block more light from entering the eye. No lens implant is perfect, and if you operate enough, you will inevitably encounter patients that are unsatisfied with their lens implant. Fortunately, it's rare, but occasionally, lenses have to come out and be replaced. Fortunately, removal of the Clearview 3 is fairly straightforward. Viscodissect around the haptics and expand the capsular bag fully away from the lens. Then prolapse the IOL into the AC and cut it in half. When I cut it, I leave the distal closed loop haptic intact. So that way, when I pull out one half of the lens, the link on the distal haptic rotates the other half out as well. Have you implanted the Clearview 3 lens? What do you think so far? How are your patients doing? I find that most of my patients really like their far and near vision, and most patients have less dysphotopsias than ringed multifocals at night. When a patient does report unwanted symptoms, it usually has to do with ghosting around letters with high contrast print. At nighttime, some patients will notice an asymmetrical flare from bright lights. However, with most patients, these symptoms will decrease over time. I've never seen a case of opacification. I know there's a concern with hydrophilicity of the lens, but there are different levels of hydrophilicity. Share your experience in the comments below. I hope you found this video helpful. Thank you so much for your attention. I'll catch you on the next one. Peace.